More than half the people walking around right now with dangerously high blood pressure have been told their numbers are fine. Not borderline, not watch it, fine. And here's the part that almost never gets discussed. They weren't lied to by a bad doctor. They weren't lied to by a broken machine. They were lied to by the reading itself, by a single snapshot taken under conditions that guarantee it won't reflect what's actually happening inside their arteries for the other 23 hours and 58 minutes of the day. Blood pressure is not a number, it's a moving target. It rises and falls dozens of times every hour in response to stress, posture, temperature, the conversation you just had, the coffee you had 40 minutes ago, whether your bladder is full, whether the nurse who took the reading was running late and seemed rushed. Your arteries don't care about the number on the chart. They care about the average pressure they are living under, year after year. And that average is almost never what the cuff says. This matters because blood pressure is the single most powerful modifiable risk factor for stroke, heart attack, kidney failure, and dementia that exists. Not one of the top 5, the top 1. Higher than cholesterol, higher than smoking in terms of pure statistical weight in large population studies. And we are systematically mismeasuring it in ways that lead millions of people to believe they are safe when they are not, and occasionally to believe they are at risk when they are not. There are 6 things your blood pressure reading is not telling you. One of them will surprise even people who have been managing their pressure for years. By the end of this, you will know exactly what to ask for at your next appointment, and you will never look at a clinic reading the same way again. If this is the kind of video that helps you, real mechanisms, real tests, real conversations to have with your doctor, consider subscribing. We're working toward 300,000 thinking, curious viewers, and you are part of getting us there. The first thing your reading is hiding, white coat hypertension, and its far more dangerous mirror image. You have almost certainly heard of white coat hypertension, the blood pressure that spikes in a clinical setting because something about the environment, the fluorescent lights, the waiting, the authority figure with the stethoscope, activates your sympathetic nervous system. Your body reads medical appointment as a mild threat. The stress hormone cortisol rises. The vessels constrict slightly. The number goes up 10, 15, sometimes 20 points above where it actually sits at home. Studies suggest this affects somewhere between 15 and 30% of patients diagnosed with hypertension. They are put on medication they may not need. They carry a diagnosis that changes how they feel about their own body for the rest of their life. But here's the thing most people don't know. There is a mirror condition called masked hypertension. And masked hypertension is the opposite problem, and a far more dangerous one. In masked hypertension, your blood pressure reads normal, or even low in the clinic, and then rises significantly the moment you walk out the door, at your desk, in traffic, at 2 in the morning when you wake up anxious. The readings that would tell your doctor something is wrong are the readings your doctor never sees. Masked hypertension is estimated to affect somewhere between 10 and 17% of people with normal clinic readings. These are people who leave appointments reassured. They don't fill a prescription. They don't change anything. And their arteries are under sustained, silent pressure for years. Both conditions are invisible to a standard clinic measurement. The only tool that catches them is ambulatory blood pressure monitoring, a device worn on your arm for 24 hours that takes a reading every 20 to 30 minutes through work, sleep, and everything in between. It is the gold standard. It is underused. And you can ask for it by name. The second thing your reading is hiding, the night. Here's a fact that changes how you think about blood pressure entirely. In a healthy person, blood pressure drops 10 to 20% during sleep. This is called the nocturnal dip, and it is not optional. It is a biological requirement. While you sleep, your heart rate slows, your vessels relax, and the circulatory system gets something close to a rest. That nightly reprieve is, in part, what allows the walls of your arteries to repair themselves. In people whose pressure does not drop during sleep, or worse, rises during sleep, the damage accumulates around the clock, 24 hours a day, 7 days a week, 365 days a year. No recovery window, no pause. The artery wall, which is lined with a delicate single-cell layer called the endothelium, never gets the signal to stand down. This pattern is called non-dipping, and it is strongly associated with increased risk for stroke, heart failure, and kidney disease, independently of what the daytime reading shows. You can have a perfectly acceptable daytime blood pressure of 118/75 and still have non-dipping that is quietly damaging your vessels every night. A standard clinic reading tells you nothing about this. Again, the ambulatory monitor is the tool, but a home blood pressure cuff used consistently at the same time each morning, before you get out of bed and before you take any medication, will at least tell you whether your morning readings are creeping up, which is one of the clues that your nocturnal pressure may be elevated. Ask your doctor specifically, is there any reason to check whether I dip at night? Anyone with diabetes, chronic kidney disease, obstructive sleep apnea, or a history of stroke has a particularly compelling reason to know. The third thing your reading is hiding, your arteries themselves. Blood pressure is measured at the surface, at the brachial artery in your upper arm. That reading reflects the pressure in one large vessel at one moment. It does not tell you the condition of the smaller arteries, the resistance vessels, that are doing the real work of regulating flow to your heart muscle, your kidneys, and your brain. These smaller vessels, over years of elevated pressure, undergo a process called remodeling. Think of a garden hose that has been left pressurized for too long. The walls thicken, the inner diameter narrows, the hose becomes stiffer, less able to expand when flow increases, less able to absorb the pulse wave that travels through it with every heartbeat. This structural change happens in the walls of the arteries at the microscopic level, long before blood pressure rises enough to register as hypertension on any cuff. And once it has happened, the remodeled artery actively contributes to higher pressure. It becomes part of the problem, not just the consequence. The clinical name for this is increased peripheral vascular resistance. You can think of it as the pipes becoming thicker walled, narrower, and less elastic, requiring the pump to work harder just to maintain the same flow. Two tests can give you information that a blood pressure reading cannot. The first is an ankle brachial index, which compares the pressure in your ankle to the pressure in your arm and can detect narrowing in the peripheral arteries. The second is a carotid intima media thickness measurement, a simple ultrasound of the arteries in your neck that tells your doctor how much the artery walls have thickened. Neither test requires special equipment at most hospitals, and both can identify arterial damage years before a standard reading would flag anything. Ask your cardiologist or internist, is my arterial stiffness appropriate for my age? The fourth thing your reading is hiding, pulse pressure. This one is almost never discussed in a standard appointment, and it may be the most underrated number in cardiovascular medicine. When your blood pressure is recorded as 130/80, most of the attention goes to the 130, the systolic pressure, the pressure when your heart contracts. The 80, the diastolic, the pressure when your heart rests between beats, gets much less attention. But the gap between those two numbers is a measurement in its own right. That gap is called pulse pressure, and a normal pulse pressure is roughly 40 millimeters of mercury. When pulse pressure widens, when you see numbers like 155/70, giving a pulse pressure of 85, it is often a sign of arterial stiffness. A healthy artery acts like a balloon. When the heart contracts and pushes blood out, the artery wall expands to absorb some of the force, then recoils to maintain pressure during the rest period. A stiff artery cannot do this. The systolic peak gets higher, the diastolic trough gets lower, and the gap between them widens. A widening pulse pressure in someone over 60 is one of the strongest independent predictors of cardiovascular events. Not the systolic alone, not the diastolic alone, the ratio between them. Next time you have a reading, do the subtraction yourself. If your pulse pressure is consistently above 60 millimeters of mercury, that is a conversation worth having, especially if you are over 50. The fifth thing your reading is hiding, blood pressure variability. We think of blood pressure as a stable number with minor fluctuations. The research over the last 15 years has shifted that picture entirely. Visit-to-visit variability, the degree to which your blood pressure changes from one clinic appointment to the next, has turned out to be a stronger predictor of stroke than the average level itself. A person whose reading is 135 at one visit, 118 at the next, 142 at the one after that, may be at greater risk than someone whose reading is a steady 140 every time. The mechanism involves the vessel wall responding to repeated cycles of high pressure and lower pressure, much like metal that is repeatedly bent back and forth. It is not the level that breaks the metal, it is the repetition of the bending. Each swing strains the endothelial lining, promotes inflammation, and accelerates the formation of the fatty deposits that lead to atherosclerosis, the hardening and narrowing of the arteries. This kind of variability is completely invisible to any single reading. It only becomes apparent when you track your blood pressure consistently over months and years. The practical action here is inexpensive and takes 90 seconds. Buy a validated home blood pressure monitor. Look for the validated label, it matters, and take readings on the same arm in the same seated position after 5 minutes of rest every morning before medication. Log them. Bring the log to your appointment. The log is worth more than any single reading your doctor will ever take. The specific brand does not matter. The consistency does. The sixth thing your reading is hiding. What is happening to you right now, emotionally? I want to stay with this one a little longer than the others because it is the factor most often dismissed, sometimes by patients, sometimes by doctors, and it may be the one doing the most silent damage. Chronic psychological stress does not raise blood pressure the way a cup of coffee raises blood pressure. It does not spike and pass, it restructures the system. When you carry sustained stress, a difficult marriage, a job that has been a source of dread for years, a grief you have never fully processed, a childhood that trained your nervous system to treat ordinary life as a threat, your sympathetic nervous system stays in a low-grade state of activation. Cortisol and adrenaline, the stress hormones, are present in slightly elevated quantities most of the time. Your vessels are slightly more constricted than they should be most of the time. Your heart is working slightly harder than it should be most of the time. And because it is gradual, and because it feels like you're normal, you do not recognize it as a medical condition. You recognize it as your life. The biology is not subtle. Cortisol directly constricts the arteries. Chronically elevated adrenaline increases heart rate and raises cardiac output. Both hormones promote inflammation in the arterial wall, the same inflammation that is the initiating event in the development of plaque. The connection between chronic stress and cardiovascular disease is no longer contested in the literature. It is as direct as the connection between smoking and lung cancer. The mechanism is just slower and quieter and easier to rationalize. Here's what I want you to consider, not as a medical instruction, but as permission to take this seriously. If there is a source of chronic stress in your life that you have been managing by not thinking about it, a relationship, a pattern of overwork, an old wound that never healed, your arteries are not ignoring it. They are keeping score. The practical actions here are not complex. Consistent, moderate aerobic exercise, 150 minutes per week, reduces the cortisol response to psychological stresses measurably. It is not about fitness. It is about giving the stress hormones somewhere to go. Beyond that, cognitive behavioral therapy has a demonstrated effect on blood pressure in patients with stress-related hypertension. And if therapy feels like too large a step right now, something much simpler, writing, without editing, about the thing that weighs on you, has been shown in controlled studies to reduce physiological stress markers over time. You do not have to send the letter. You do not have to share it with anyone. The act of externalizing what the body has been carrying internally is, on its own, a form of medicine. Take this factor as seriously as your salt intake. More seriously, probably. Before the summary, drop your age in the comments and whether you have ever been given an ambulatory monitor or not. I'm genuinely curious how many people in this audience have had that test recommended to them versus how many have been managing their blood pressure for years on clinic readings alone. It shapes what I make next. Here is the summary, in the order that matters. Blood pressure variability is the highest priority issue most people are not tracking. Start a home log this week, every morning, same arm, same time, same conditions. Bring it to your next appointment. White coat and masked hypertension are next. Both are common, both are invisible to clinic readings, and both are fully detected by ambulatory monitoring. Ask for it by name if you have any reason to suspect your clinic readings are not representative. Nocturnal non-dipping is third, particularly relevant if you have sleep apnea, diabetes, or kidney disease. The question to ask is simple. Should we check whether my blood pressure drops at night? Pulse pressure. Check it yourself right now from any recent reading. Subtract the diastolic from the systolic. Consistently above 60, especially if you are over 50, is a conversation to have. Arterial remodeling. Carotid ultrasound and ankle brachial index are the tests that see inside the walls. They are available, underutilized, and worth asking about. And chronic stress, not as a lifestyle tip, but as a physiological driver that the cuff cannot capture and that will not resolve because you decided not to focus on it. The minimum viable screening protocol. A validated home blood pressure cuff, a morning logging habit, an ambulatory monitor if your readings are inconsistent or your risk profile warrants it, and a conversation with your doctor that includes the words pulse pressure, nocturnal dipping, and variability. The specifics are always individual. Take what is useful here, but run it by someone who knows your full medical history before you make any actual changes. If this gave you something useful, a question to ask, a number to check, a test to request, the subscribe button is right there, and it takes 1 second. We are building toward 300,000 curious, engaged viewers who take their health seriously, and you are part of that. We will see you in the next one.